Commonly prescribed medications can have varied effects on sleep. Some can interfere, like sildenafil worsening severe sleep apnea, while others, like proton pump inhibitors, improve it in patients with gastroesophageal reflux disease or GERD. So clinicians need to consider these effects alongside potential therapeutic benefits, especially since sleep issues are so common in primary care and patients are taking many medications. I'm Dr. Klugherz. I'm a resident physician in my final year of training in psychiatry at Mayo Clinic. And alongside my colleagues, Dr. Mansakani and Dr. Kola, we published a review called The Effects of Commonly Prescribed Medications on Sleep, a review of the literature. And this will be appearing in Mayo Clinic Proceedings. To review the findings, the review looked at how 7 commonly prescribed medication classes, antihypertensives, statins, antidepressants, levothyroxine, proton pump inhibitors, PPIs, PDE5 inhibitors, phosphodiesterase 5 inhibitors, and metformin affect sleep, which is, of course, a frequent concern in primary care. So key findings are broken down like this. Antihypertensives, or the blood pressure medications, beta blockers often cause fatigue and somnolence, and sometimes nightmares. Diuretics can improve obstructive sleep apnea, but they may contribute to an increased risk of nocturia. As you might suspect, angiotensin converting enzyme inhibitors, ACE inhibitors, angiotensin receptor blockers, or ARBs, and calcium channel blockers, CCBs, tend not to affect sleep very much. Statin medications prescribed for cholesterol and other uses have minimal sleep impact, with very rare cases of insomnia. With antidepressants, there are different effects on sleep depending on the medication. Some, like trazodone, can increase the risk of sedation, while bupropion can contribute to insomnia. Other antidepressants seem to have variable effects on sleep depending on the dose. Interestingly, levothyroxine doesn't appear to disrupt sleep, and there's actually evidence suggesting it may help regulate thyroid levels more smoothly when taken at nighttime, even though the common recommendation is to take levothyroxine in the morning. PPIs, the proton pump inhibitors, seem to improve sleep in patients with GERD. Phosphodiesterase 5 inhibitors, like sildenafil, can worsen severe sleep apnea, and it's not exactly clear why that is. Metformin seems to have a neutral effect on sleep with some hints of benefit, especially in certain populations like adolescents with polycystic ovarian syndrome. Overall, it's a mixed bag with these commonly prescribed medications, so clinicians need to weigh these effects against the potential therapeutic goals. So in clinical practice, these findings encourage a tailored approach to prescribing, which is how medicine seems to be moving. For example, if a patient with hypertension reports fatigue or vivid dreams, the clinician might choose to avoid beta blockers and opt instead for an ACE inhibitor or an ARB, which evidence shows have less impacts on sleep. For someone with GERD and poor sleep, PPIs could help with both issues. On the other hand, for a patient with severe sleep apnea needing a PDE5 inhibitor, the clinician might want to evaluate and manage the sleep apnea as best as possible first, since evidence suggests that sildenafil could worsen the sleep apnea. They also might consider diuretic therapy in that case, since there's evidence it could improve sleep. Overall, the review emphasizes balancing benefits with sleep side effects, especially since over 50% of adults take prescription medications, and sleep complaints are so common in the primary care population. For patients, this means that medications might affect their sleep, for better or worse. There are many common medications that are not sleep medications, but they could still have an impact on sleep. If a patient's feeling groggy on beta blockers or sleeping better with proton pump inhibitors, it might not be random. It could be at least partially related to the medication. They should feel empowered to talk to their doctor or pharmacist or whoever prescribes their medications about sleep changes, because tweaking the prescription or timing could make a difference in how they feel day to day. Future reviews could expand on these results to include other commonly prescribed medications in primary care with less available evidence on sleep, as well as therapies with growing utilization or popularity. So for example, GLP-1 agonists or the glucagon-like peptide-1 agonists. Additionally, more research is needed to explore the mechanisms by which these medications interact with sleep disorders like restless leg syndrome or obstructive sleep apnea, as well as how timing, dosage, and patient comorbidities influence these effects. Bigger, longer-term studies with objective sleep measures like polysomnography might really strengthen the evidence as well. My colleagues and I would certainly invite you to read this article in Mayo Clinic Proceedings to learn more about the specifics of how these classes of medications affect sleep.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.